end of the big toe to the skull. The skull. This is a nervous system. So a lesion can be anywhere. Number two, the site of the lesion, especially for the students, is different from the cause. When they ask you about where the site is different about when they ask what is the cause. So the site is different from the cause. Number three, the more the signs, the higher the site of the lesion. If you have a patient who's got too many signs, the lesion is higher. For example, patient with spastic paraparesis. Spastic paraparesis. And you had 4 signs in the legs. Weakness, hypertonia, increased reflexes, and ongoing plantars. These 4 signs. If you add sensory level, 5 signs, that means the lesion is a little bit higher. If you add the involvement of the upper limbs, same signs of the upper limbs, that means the lesion is cervical or cortical. If you have cranial problems with this upper or lower limb signs, that means the lesion is higher than the cortex. So the more the signs, a patient with just foot drop. So the lesion might be, the size of the lesion might be just above the level of the knee in the fibular region. So the more the signs you elicit, the higher the size of the lesion. And the good the clinical examination, the accurate the size of the lesion. If you are good in eliciting the signs, you will be very good in localization. If you have a patient with spastic paraparesis and you find a sensory level at the umbilicus, close your eyes and say the size of the lesion is at the umbilicus or T9, T8, T9, T10 level. So if you are good in eliciting the signs, you'll be very good and you'll be very accurate in localizing the size of the lesion. And shall I mention that, especially for the students, investigations are not for localization. Don't say I'll do an MRI scan to localize the lesion, or I do CT scan to localize the lesion, or do nerve conduction study. Investigations are for, number one, confirmation of the clinical site of the lesion. If you say by examination, this patient has sensory level at the umbilicus. So the lesion at the umbilicus. I will do an MRI scan of the lower thoracic spine. And the MRI scan will confirm, I'm not talking about the cause, will confirm that there is a lesion, whatever that lesion is at the umbilicus, consistent with your clinical diagnosis, number one. So the investigations, number one, for confirmation of the clinical status of the lesion. Number two, ruling out other clinical differential diagnoses. If I say differential diagnoses are 1, 2, 3, patient, for example, with headache and bilateral papilledema. In this case, the MRI scan is not to confirm the clinical status of the lesion, it's to rule out the other possibilities. If I say this most likely specific lesion or arterial malformation or benign hypertension, I will do an MRI scan. Number one, to rule out specific lesion, but it will not rule out BIH, a normal MRI scan. So the investigation we ask for, number two, is to rule out some of the clinical differential diagnosis. Number three, to identify the cause. This is the least part of the investigations. We do the MRI scan to identify the cause. Clinically, this patient has a lesion at the umbilicus causing spastic paraparesis with the sensory level. The MRI scan will tell you whether transverse myelitis, this prolapse, this herniation, cord compression, both disease of the spine. It will tell you the cause. So this is very important, 5 points. Number one, where is different from what is. Where is different from what is. The site of the lesion is different from the cause, especially for the students. The more the signs, the higher the site. And the good examination, good history, good examination will lead to accurate or good diagnosis. Investigations are for confirmation of the clinical site, ruling out some of the clinical differential diagnosis, and identifying the cause. Is the reason for the investigations. طيب. Example, why you need to localize the site of the lesion? Why we need to do clinical examination to localize the site of the lesion? Number one, to create a clinical differential diagnosis. To create a clinical differential diagnosis. Number two, to investigate the right area. If you have a patient with spastic paraparesis and a sensory level at the umbilicus, I will investigate the right area. I will not lose my time, waste my time and waste my money to do the MRI scan of the brain or cervical spine, which will be normal because the lesion is the umbilicus or dorsal cord. To choose the right test. To choose the right test. If you think the cause is cord compression, I'll go for the MRI scan. If you think it is infection, I'll go for lumbar puncture. So the purpose of localization. When you localize the lesion, you will be able to use the right test to create differential diagnosis and to investigate the right area. It's very important. If you don't examine the patient, you will not be able to investigate the right area. And you have to choose the right test according to the cause. Example, 40 years old lady with right-sided facial weakness. It's a very, very common case, and we see it in the clinical practice, in the ward round or in the outpatient clinic. A patient with facial weakness, every time we see them. The site of the lesion will be the left hemisphere if it is a lower motor neuron. If it is an upper motor neuron. If you examine this patient, we said we had about 25 lectures in symptoms and signs of neurology. If you examine this patient and she had the right upper motor neuron lesion, I would say the lesion will be in the left hemisphere. Because the left hemisphere supplies the left side. This is a localization. For this patient, with the features of lower motor neuron, the localization in the left hemisphere. I will do an MRI scan of the brain. Same patient, if it's a lower motor neuron, not upper motor neuron, the lesion will be in the bones. The lesion might be, number A, in the bones, where the nucleus of the facial nerve. And with this, you might find plus or minus other cranial nerves palsy. I will do an MRI scan. If I think this patient has got lower motor neuron facial weakness, I will go for an MRI scan if I think the lesion in the bones. If it's an upper motor neuron, the only test to do is neuroradiology. Either CT scan or MRI scan. We'll do an MRI scan. If the lesion in the bones and it is a lower motor neuron, and the lesion most likely in the bones, if you found other kind of involvement, beside the facial nerve, we have the abductor nerve, we have the seventh nerve, fifth and eighth nerve. All of these four nerves are in the bones. I will do an MRI scan. If the lesion is cerebellopontine angle, same lady with facial weakness, but she has involvement of the fifth and eighth cranial nerve. She's deaf in the ear, and she had the evidence of trigeminal neuropathy. So, cerebellar signs. So in this case, I will do an MRI scan. I would say most likely the lesion in the cerebellopontine angle. Why I did not say the lesion in the bones? Because in the cerebellopontine angle lesion, I will find fifth, eighth nerve palsy with cerebellar signs. Okay? Or the lesion in the internal auditory meatus. For example, Ramsey-Hunt syndrome. I don't do any MRI, I don't do a test. If examination showed that this patient has herpes infection in the ear, which is small area supplied by the chordae tympani for sensation, and there is a rash there or vesicles, that means this Ramsey-Hunt syndrome, and I don't do any test. We don't do any test. Obvious, this is Ramsey-Hunt syndrome. Okay? And no test will be done. If the lesion is extracranial, in the mastoid area, or the parotid gland, again, this is an extracranial cause for facial nerve palsy, no test. I put this example, dear brothers and sisters, to show you that. And same patient, if you see same patient, if you see 5 patients with the same right side facial weakness, for 2 of them I'll do test, or for 3 of them I'll do MRI scan. For 2 of them, no need to do any test. If you do test, it's going to be normal MRI scan. And for the first one, the site of the lesion is different from the second, from the third, from the fourth. This is the joy of localizing the lesion. When you see a patient, same patient, with an upper motor neuron, the site is different. If it's a lower motor neuron, it's different. If it's a lower motor neuron with 6th nerve palsy, 7th or 8th nerve palsy, it's different. If there is 5th nerve palsy, 8th nerve palsy, and cerebral signs, or cerebral triangle, it's different. If the patient got rash in the ear, we call it Ramsey-Hunt syndrome, it's different if she had a scar behind the ear, or if she had pituitary enlargement, not pituitary, parotid gland enlargement, parotid stone, or parotid tumor. I hope this example is very clear. So we tell you the site of the lesion is different from every patient. If you take this out 6 or 7 patients with the same right side facial weakness, the site of the lesion is different, and the treatment is different, and the investigation is different. Let's take example number 2. A patient with right side Horner syndrome. Horner syndrome is a lesion in the sympathetic chain. We have the sympathetic and the parasympathetic. The parasympathetic, for example, for eyes, it goes through the 3rd nerve. The sympathetic, it goes through the sympathetic chain. Horner syndrome has got 2 sides of the lesion, intracranial or extracranial. I might show a patient in the exam with Horner syndrome, and the signs are limited. There are not too many signs. Partial ptosis, you must find end of thymus, the eyeball will be inside, a little bit inside than the other one, and the pupillary, the pupil will be constricted, differentiated between Horner syndrome and 3rd nerve palsy. In 3rd nerve palsy, as we mentioned last time, the pupils are dilated, but in Horner syndrome, the pupil is constricted. So if you see a patient with these features, end of thymus, and hydrosis might be dry around the eye, I don't see that sign clinically. But partial ptosis, never complete ptosis, because it supplies only one muscle, we call it the molar muscle, supplied by the sympathetic chain. And then the pupil is constricted. So the lesion of the sympathetic chain might be intracranially or extracranial cause. Intracranial might be in the cortex, might be in the brainstem, might be in the medulla, we call it lateral medullary syndrome. This is why patients with lateral medullary syndrome develop Horner syndrome, because the lesion, the sympathetic chain passing on the lateral part of the medulla along with the pyramidal tract. Or patient may have extracranial lesions or causes, extracranial causes for the Horner syndrome, especially when the sympathetic chain passed unprotected on the soft tissue of the neck. So there might be carotid dissection, carotid aneurysm, lobular goiter, lymphadenopathy, pancreas tumor. All these can compress the sympathetic chain and cause Horner syndrome. So if they show a patient in the exam with Horner syndrome, look for the site of where the site of the lesion. Say it could be intracranial, which you can't see it, and in that case you need to do the test to localize it, or to know the cause, or extracranial. The good doctor in the exam, or the good medical student, when you see a patient with Horner syndrome, immediately I will look at for external cause, because internal cause you can't see them. The internal cause you can't see them. You have to look for extracranial causes. Look for carotid pruit, okay? Feel for carotid aneurysm, lobular goiter, lymphadenopathy, and percuss for pancreas tumor. And look for a scar. Sometimes there's a scar, but we don't do it now. Before they do jugular, the patient theater or the critical care, they do jugular foramen, jugular venous line. But now we do the brachial. So a scar, look for a scar, feel for lymph nodes, goiter, or Bankos tumor, and listen for carotid fluid. This is the extracranial cause. Some patients in the exam, when you give them Horner syndrome, they don't know that there are extracranial causes. Exactly the facial nerve. Any patient with lower motor facial weakness, you have to look behind the ear, you have to look inside the external ear, and you have to feel the parotid to look for extracranial causes. Ramsey syndrome, parotid tumor, and scar, mastoid scar. Any patient with Horner syndrome, after you confirm it is Horner syndrome, and not third nerve palsy. If it's third nerve palsy and you're looking at the neck, you will fail the case. You will fail the case because there is no causes of third nerve palsy in the neck. Third nerve palsy injury is mainly intracranial because it does not exit the cranium. So when you see a patient with Horner syndrome, to get the full mark, confirm it's Horner syndrome, and say to the examiner, I would like to examine for extracranial causes for Horner syndrome. What are the extracranial causes? Mainly in the neck, aneurysm, dissection, lymph nodes, goiter, lobar goiter, and you have to percuss the apex of the lung for Bankos tumor. The third example, if you have a 51-year-old man with left third nerve palsy, you confirm it is third nerve palsy by partial or complete ptosis, dilated pupil, and ophthalmopathy. Some of the muscles supplied by the third nerve are weak, medial rectus, superior oblique, and inferior oblique. Superior rectus and inferior rectus, and inferior oblique, and medial rectus. So if you confirm this third nerve palsy, you have to localize where is the lesion. Because the course of the third nerve palsy is long. The nucleus lies in the midbrain, and it passes for a short distance in subarachnoid space to enter the cavernous sinus and exit the cavernous sinus to enter the orbital area, and then divide into branches to supply the muscle of the eye. So anybody will know this is third nerve palsy, but who is good in localization and on what base you localize third nerve palsy clinically. Not talking about the investigation-wise or radiologically. So, could be in the midbrain. Midbrain. It's difficult to say this 100% midbrain because there is no other science to tell you that it is in the midbrain, but there's a possibility. Rarely, a large lesion may involve both fourth and third nerve palsy. Could be in the subarachnoid space. This is a common size for the third nerve palsy, subarachnoid space. Because the nerve, after exit from the midbrain, it passes for a short distance before it enters the cavernous sinus. So it might be labeled, and this area which the nerve cross is very vascular. It comes just under the anterior communicating artery and the posterior communicating artery and the two cerebral arteries. So, and the other side is in the cavernous sinus and might be in the interorbital area. On what basis I would say this is pure third nerve palsy? Don't say pure third nerve palsy unless you make sure that there is no other nerves are involved. If you found third nerve palsy without any other cranial palsy, I'll go for these two, midbrain and subarachnoid space. Especially if it's with headache. Headache, it will go to this one, most likely rupture of aneurysm in the subarachnoid space. So midbrain lesion, subarachnoid and cavernous. Cavernous sinus is obvious. Symptoms are different, and the signs may include the fourth nerve palsy and sixth nerve palsy and the ophthalmic and the maxillary division of the trigeminal nerve. And the lesion may be in interorbital facial lesions usually might affect other cranial nerves as well, because usually it's either cellulitis or tumor and might cause some degree of oxophthalmos. So this is an example of localization, how to localize a lesion to third nerve palsy. By the way, any sign in neurology has localization. Any sign has localization. Sometimes one sign has more than one localization. For example, is foot drop foot drop might be from peroneal nerve palsy at the fibula or the knee, and the lower back, L5S1, can cause foot drop as well. طيب, S plus S equal S. S plus S equal S. The first S is for symptoms. The second S is for signs. And the other S is from sight. Symptoms plus signs equal sight. Which is more important in localization? This S, the red S, orange S, or the green S? Sorry, which one is more important? This symptom or signs in localization? If someone asks you which you would like to have plenty of symptoms to localize the disease, or signs to localize the site of the lesion?
Why?
Why no symptoms? For some conditions, we just rely on the history. Epilepsy, for example, migraine, the examination is normal, no signs. Epilepsy, there's no signs. So we take the symptoms, because symptoms again are subjective. We take the symptoms and we would like to confirm the site by signs. You have to find signs.
Bakit? Bakit? Dalawa tayo. Yan ka, gusto ko tayo mo. Yun mo sa akin yan.
Okay. So S plus S equals S. Keep this equation. It's very important and it will help you in localization. Symptoms plus signs equal sight. S plus S equal S. S for the students, the first S for symptoms, the second S for signs, and the third S for sight. If you are good in taking the history, we spent many lectures about taking the history from neurological patient and examine the patient, signs, and then you get to science. Right. The neurological signs are too many signs. I'm afraid you should know most of them or all of them, because everyone is very helpful. Everyone has got different localization. Sometimes got combination of that. Eyes has got the maximum number of signs are in the eyes. Exophthalmos is a sign. One eye protruding outside might be due to something pushing from behind. Anophthalmos is a sign, and we see it in cluster headache, we see it in Horner syndrome. Dancyllasma is a sign of hyperlipidemia, and xanthoma. Dancyllasma is deposition of lipids in the eyelids, and xanthoma just above the eye and the scalp. Sorry, the skin above the eye. Corneal arcus, deposition of lipids around in the cornea, either pathological or physiological. Ptosis, drooping of the eyelid. Ptosis has got two types, either partial or complete. By the way, eyes, all the time, either right side or left side, bilateral or unilateral. You have to use this terminology because the differential diagnosis of a unilateral ptosis is different from bilateral ptosis. Pupillary abnormalities. For your level, we take constricted pupil, either bilateral or unilateral, dilated pupil, bilateral or unilateral, or Arkaskan type of pupil, we see it in optic neuritis, or Robertson giant pupil, we see it in diabetes, syphilis, and then we have Homoadi pupil, we see it in isolated syndrome, which associates with hyperreflexia. So pupillary abnormality will cover that when you talk about the neurophthalmology. And one of the signs dies is visual field defect. The most important for us as neurologists is bitemporal hemianopia or homonymous hemianopia. The ophthalmologists, they have different classification of visual field defects because they use the machine sometimes to detect even a small area of defect. It can be detected by the machine. And then we have nystagmus, which it is 3 types: horizontal, vertical, or rotatory. Nystagmus is a sign. Is a sign, as it could be physiological or could be pathological. Visual field defect is always pathological. Pupil abnormality could be physiological because some people will go to a dark area, there might be dilation to pupil. When they go to bright light, there may be constriction. But bilaterally dilated pupil is death. Bilateral constricted pupil is pontine hemorrhage or medication. Impaired cornea reflex. Very important, cornea has got reflexes. One of the brainstem reflexes modified by 2 nerves, the 5th and the 7th. We talk about Bell's sign or Bell's phenomenon. We see it in lower motor and facial weakness. We talk about ophthalmoplegia, paralysis of the eye muscle, lateral rectus, medial rectus, superior oblique, inferior oblique, superior rectus, inferior rectus. And we talk about papilledema, which is indicating increasing cranial pressure behind the eye. And we talk about optic atrophy, which we see either idiopathic or due to chronic papilledema or due to recurrent optic neuritis. So there are some more signs which might not be of great importance to neurologists, like dislocation of the lens, Kessler Fresher ring, and brush field abnormality in Down syndrome. This is all these signs are in the eye. We have some signs in the hands and arms: tremor, wrist throb, claw hands, muscle wasting, finger clonus, percussion, myotonia, fasciculation, impaired biceps and tricep reflexes. These are the signs in the hands. In the legs, they may show a foot drop, bus cavus, ankle clonus, increase or decrease ankle reflexes, upgoing plantar, loss of position sense, muscle wasting, fasciculation, or breast knee jerk. These are the signs you can elicit in the legs. In the face, so look, face and eyes, too many signs. You can, by examining the face and the eyes, it's very informative. Examination of the face is very informative for you when localization. Stage Weber, which is red pontine or red discoloration, strawberry-like discoloration of the area supplied by the face nerve. Neurofibromatosis, in the face. Tuberous sclerosis, always seen in the face. Herpes rash, like herpes zoster, affecting the ophthalmic division of the trigeminal nerve. Dystrophy myotonic face has 6 or 7 signs. Parkinson face, 6 or 7 signs. Facial weakness, 2 or 3 signs. Tardive dyskinesia, peripheral spasm, wasting of the tongue, deviation of the tongue, fasciculation of the tongue or facial muscle. Impaired gag reflex, which again, brainstem reflex, supplied by the 9th and 10th. Frontal baldness, we see it in dystrophy myotonic. So these are the signs in the face and mouth. And then we have the signs of nystagmus, kind of speech, action tremor. These are cerebellar signs. Cerebellar signs are bilateral, horizontal, fine or coarse nystagmus with high or fast component to solve the lesion, scanning of speech, action tremor, dysmetria, dysdiadokinesia, ataxia, and pendulum reflex. These are the cerebellar signs. And then we have dysarthria, scanning of speech, which is due to cerebellar lesion, monotonous speech due to Parkinson's disease, and nasal speech due to MND and myasthenia gravis. The gait, we have the normal gait, hemiplegic gait, hemiplegic or hemiplegic gait, we call it high circumference gait, spastic gait, shuffling gait, Parkinson, ataxic gait in cerebellar dysfunction, high stepping gait or high steppage gait, both are right, stamping gait, waddling gait. And then we have the tone, spasticity, flaccidity or flacidity, and rigidity. So imagine there are too many signs Oh, I'm very confused. How can I learn all this science? You can. If you are systematic and you organize yourself, you will know all this science. But then they are that big number. There are more than 40 science. You can list more than 40 science. How can I do that? You can. If you keep practicing neurology and you know the signs of every disease, you just put them together and you'll get out with this table. So don't frighten with this table, especially for the students. This is just to guideline you that there's too many science. The good thing about, as I mentioned in one of the lectures, that the good thing about the neurological condition, they leave signs. Any dysfunction of any part of the nervous system, it will leave sign, which will help us in identifying the defect or the pathology in that area. If you cut your peroneal nerve, there will be a sign, there will be foot drop. If you cut your radial nerve here and the humeral groove here, you will have breast drop. If you have Horner syndrome, if you cut some section, you will have pubic abnormality, you will have ptosis, and you will have enophsalmus. So any part of the nervous system, luckily, in a way that it can cause signs to help the clinician. It's bad for the patient, yes, but in generally, it might help us to diagnose the cause, we might find treatable cause. Like any other system, neurology, there are some untreatable disease. Every system will be not treatable, untreatable disease, but there are some treatable disease, especially with advance in the pharmaceutical products, as we can treat so many conditions. And the science, for example, cerebral signs are limited. We talked last week about cerebral in basis. Cerebral disease, the signs are very limited and very easy to pass a cerebral case. Because the signs are very limited, and as I mentioned, they might introduce a patient with the same in different ways, through speech, tremor, dysmetria, ataxia. So you have to keep open-minded. When you're facing, especially if you're going for the exam in neurology, just keep your mind open for any possibility of any, because sometimes you may have unexpected case in the exam. Any case, any neurological disease can be in the exam for both the students and for the basis or Arab board or local MDs or for the fellows. So I can examine a patient with motor neuron disease, medical student, to elicit the fasciculation, to do the reflexes, and can examine the basis student in that case, and can examine a follow student in that case. For every level, I will give different options on the level of the. So this is the good thing about neurology. We don't have too many, we have limited number of conditions. And the signs are there all the time. There is no change in sign. There is no developmental in sign. The signs of the eyes are like when we taught when you're a medical student, the same. They're going to remain the same. And I pass them to others, and you will pass them to your student, and that. So the signs are the same. The development might be in investigations. For example, in the last 4 or 5 decades, we have very good development in neurology. And recently you have development in the treatment. For example, migraine, now we use monoclonal injection, which is very, very helpful in reducing severity and the frequency of the attacks. But the signs will be the same. The cerebellum will be the same cerebellum. Yes, every now they might discover new function of the cerebellum and they add it to the previous function. For example, now they found that cerebellum is very important in memory as well. So they will just add it to the cerebellum, and the sign will be the same. There is no change. So if you have a good base of neurology, you will be good forever. Because the same, not going to change. If I give this lecture today, and after 10 years, I can give the same lecture for different students. But there is no change in science. The change, the talk will be different in investigations after 10 years, for example, and in treatment, or in diagnosing the cases. But the signs will be the same. I hope that we get this message. Okay? The site of the lesion. Where is the lesion in neurology? Where is the lesion in neurology? This is a very important question to ask. And a very important question to answer. If you see any case in the exam, neurology case, expect this question: where is the lesion? There are too many different sites of the lesion. The lesion might be in the central nervous system.
Additional file is the request is there.
The lesion might be in the central nervous system.
All right.
We call it upper motor neurons. Central nervous system. Can you please mute yourself, please? The central nervous system includes the brain and the spinal cord. We call it CNS. We call it upper motor neuron lesion. This is one of the localization. If you say this patient has got weakness of both legs due to upper motor neuron lesion, that means the listener, somebody who never seen the patient, if you're talking on the phone, I will understand from what you are talking that this patient, the lesion is either in the spinal cord or in the brain, from what you are telling me, upper motor neuron. And then we have peripheral nervous system, the peripheral nerves and your muscular junction, anterior horn cells and peripheral nerves. So this is a lower motor neuron. This is a lower motor neuron. If you say this patient got spastic paraplegia, is different from flaccid paraplegia. The site of the lesion is different. So these are two locations. I'm sure that you know both of these as medical student or senior doctors. So either upper motor neuron, when you say this is an upper motor neuron, halas, you commit yourself that this patient has got a lesion in the brain or in the spinal cord. If you say this is a lower motor neuron, so this is the site of the lesion. Peripheral nerves, neuron cells, or neuromuscular junction. This is a lower motor neuron lesion. The lesion, another classification of where the lesion could be intracranial. Intracranial means a lesion in the structures inside the cranium. Cranium means the skull, is the Latin word, inside the skull. This includes the brain, and it is part, for example, brain lobes, brain stem, and cerebellum. Call it intracranial lesion. And then we have extracranial lesion. Extracranial lesion, that means a lesion in the spinal cord or the peripheral nerves. Funny enough, if I say this patient has got intracranial lesion, that is going to be all the time upper motor neuron. Intracranial means upper motor neuron. But extracranial can be either, because extracranial includes the spinal cord and the peripheral nerves. Is that clear at this point? When we say this patient got intracranial, this is always upper motor neuron, because it's the brain, intracranial. But when you say extracranial, you are including the spinal cord and the peripheral nerve. So there might be an upper or lower motor neuron. But intracranial, always upper motor neuron, because a lesion will be in the brain or in the part of the cranial structure. Extracranial could be upper motor neuron, could be lower motor neuron. Sometimes they put it in for the students in the multiple choice questions. Extracranial could be either both, upper or lower motor. And then we have a lesion in the, when you come to more details of the extracranial. لو سمحت mute yourself please. Please mute yourself. So intracranial has got two sides. Either hemispheric lesion. If you say this patient got right hemispheric lesion, I will accept it from the students, medical student. If I show a medical student, a patient with left-sided hemiparesis, and the student say there is hemiplegia affecting left upper lower limb, the lesion may be in the right hemisphere. I'll accept it. But for people going for the membership or PACES exam, you have to localize the lesion to the brain lobes. Which part of the right hemisphere? We've got 4 brain lobes. Frontal lobe is the lesion in the frontal lobe, is the lesion in the parietal lobe, is the lesion in the occipital lobe or temporal lobe. So, and always link it to right or left. This man has got the features or the signs, the symptoms point to a right frontal lobe region, or left frontal lobe region, or right occipital nerve, or right occipital lobe region. You have to be specific. Brain lobes is a localization. So when you say right frontal lobe, right frontal lobe, these are 3 localizations. Number 1, intracranial. Number 2, right side. Number 3, brain lobes, frontal. These are 3 localizations. Sometimes you have 4 or 5 localizations in one patient. When you say you are very specific. When you say the signs and symptoms of this patient pointing to left frontal lobe lesion. Frontal lobe lesion. You will have 10, 10, 10. You might get 30 out of 30. Because you say right, the localization, you localize the lesion to the right side. Because the symptoms are on the left side, symptoms signs on the left side. And frontal, because you have some feature frontal lobe, some sign frontal lobe lesion. And intracranial, because the frontal lobe is the brain. So we've got the full one. The second side of the lesion is brain stem. Brain stem. If you say most likely the lesion is in the brain stem, you're localizing, but you'll not get the full mark. You'll get the full mark if you mention which part of the brain stem. As we just mentioned, based on a patient, he has 3rd nerve palsy and 4th nerve palsy. Close your eyes, say the lesion is in the midbrain. This is 3 localization. Intracranial, brain stem, and part of the brain stem itself. You said the midbrain. Or most likely the lesion in the medulla, is lateral medullary syndrome. On what basis you say lateral medullary syndrome? Because I've got features, I've got symptoms and signs. In the Horner syndrome, and the cerebellar signs, and the pyramidal signs, and the hemisensory problem, the lesion most likely in the left medulla, or the lateral part of the left medulla. This is more advanced localization. You will get full mark. So when you say brain stem, you will get some marks, but you will not get the full mark unless you say which part of the brain stem, because the brain stem has got 3 parts, as midbrain, bones, and medulla oblongata. And the lesion might be in the basal ganglia. And it will be more, it's difficult to say which part of the basal ganglia, but if you may say this is thalamic area, subthalamic area, the red nucleus, in anterior capsule of the basal ganglia, posterior cap, you will get more mark. Anterior limb of the basal ganglia, posterior limb, you will get full mark, because basal ganglia itself is the localization. Depending on the signs, I say most likely this patient got problems with the basal ganglia. And because of so and so, I think might be subthalamic area. This is a localization. And then we say the cerebellum. We don't see the cerebellum. Patient with cerebellar infarction, we don't see it. I can't see it. Cerebellar bleeding. But from the history and the clinical examination, I would say most likely this patient got a lesion in the right cerebral hemisphere, or in the middle of the cerebellum, or bilaterally, both hemispheres involved. This again is a super localization. You localize intracranial, you localize cerebellum, not cortex, and in the cerebellum, you localize which parts of the cerebrum, right or left, and whether it is hemispheric or the center of cerebral lesion. And then we have the bulbar pathway. We'll talk about that in a minute. And then we have pseudobulbar pathway. And then we have cavernous sinus. Why you say this patient? Most likely is a lesion in the cavernous sinus. You came back to your neuroanatomy. We know that the cavernous sinus contains the carotid siphon, the third nerve, the fourth nerve, the sixth nerve, and the ophthalmic division, and the maxillary division of the trigeminal nerve. Patient will come with complete ophthalmoplegia. Painful ophthalmoplegia due to involvement of the ophthalmic division of the trigeminal nerve. And they might come with headache and fever if it is Trout syndrome. So complete ophthalmoplegia, close your eyes, put the lesion in the cavernous sinus, not in the brainstem. Because unless you've got a massive brainstem to affect all the three nerves. So cavernous sinus, because the three nerves lie to each other. But in the brainstem, two nerves in the midbrain and one nerve in the bones, the sixth nerve in the bones. So cavernous sinus is the site of localization. And then we have cerebellopontine angle. Why I say this patient the lesion in the cerebellopontine angle? Because there is evidence of seventh nerve palsy, fifth nerve palsy, and eighth nerve palsy, and may have cerebellar sinus if the lesion is large enough. So cerebellopontine angle, CBA, is the site of localization. And then we say jugular foramen. I never seen a jugular foramen I never see it unless, except our students when we were doing the neuroanatomy, I saw the cavernous sinus or jugular foramen, but I never seen it after graduation. But I diagnosed so many cases with the lesions and the jugular foramen, and the diagnosis tend to be right. Not by magician or not by ultraviolet light or whatever, just by putting the sign symptom together, and the MRI scan will confirm it. So jugular foramen is a foramen where the lower nerves will be involved. 9th, 10th, 11th, and 12th. Although 12 is not part of the jugular foramen, but it's very close to the exit of the nerve, so that might be involved. Cranial nerves, localization. If you say this patient got facial nerve palsy, you're localizing. Two localization, cranial nerves and intercranial. But if you say right facial nerve palsy, this is super localization, full mark. And if you add upper or lower, you get excellent, alas. When you say to me, just an example I gave you, this man on examination most likely has upper motor neuron left facial weakness. Alas, I know that the lesion should be on the hemisphere or just severe to brainstem. This patient on examination, he has left-sided lower motor neuron facial weakness. Plus, your listener should understand that the lesion will be in the nucleus or infranuclear fibers. This patient has got lower right-sided facial weakness plus hearing problem and trigeminal neuropathy, pain or weakness of the muscle of mastication. Halas, cerebellopontine angle, plus or minus cerebellar sinus. So the cranial nerve is localization, but right or left is very important, and upper or lower motor neuron is very important because any information will change the site of the localization. Could be in the vision pathway. Vision pathway is localization. Anything that has got long pathway, because the lesion might be at different levels. So the vision, imagine that the eyes are here and the vision center in the occipital area, about 10 to 12 centimeters, this distance from the eyes to the occipital area. The vision pathway is the long pathway is liable to injury at different sites. Sometimes any lesion affecting the parietal lobe, affecting the anterior part of the occipital lobe, optic chiasm, pituitary, can cause vision pathway pathology because of the long pathway. So you have to know how to localize a lesion in the vision pathway. We'll come to that inshallah in the future. And then craniovertebral junction. Craniovertebral junction anomaly. So the craniovertebral junction, patient may have pyramidal and cerebral signs. We discussed yesterday the cause of combination of pyramidal and